Hi, this is Dr. Tom Rafai, and I am a board-certified internal medicine specialist, one of only 60 question writers for the American Board of Internal Medicine, actually worldwide. I am also certified by and a leader in lifestyle medicine and a past president of the National Board of Physician Nutrition Specialists. I was actually one of the inaugural question writers for the obesity certification exam. Obviously, I wrote questions for the National Board of Physician Nutrition Specialists exam as well, and I am the first physician ever certified by the Cardiometabolic Health Congress as a certified cardiometabolic health specialist. So it pains me today to have to critique a colleague that put out a video on why he orders his own blood tests and does not see a doctor and discourages people from seeing a doctor because of an overly simplified uh, feeling that the American health system is beyond repair and has nothing to offer whatsoever to people, and therefore they should get their own lab work and try to interpret it themselves and potentially miss things. And you can already see the problems that I see associated with educating people on labs, but then telling them they should just simply order them on their own and take care of the results on their own without seeing a physician, which I personally believe is a step towards, if not frankly, in the realm of malpractice. So, and I have done free videos on how to interpret lab work. They're on YouTube. There's an entire continuing education course I did that is free to the public with Orgain on how to interpret metabolic labs and the actual target ranges and what they mean, which wasn't happening in this video that I'm going to share with you, and combined it with a great presentation on how to coach based on stage of readiness for change, which might even be interesting to you. So I'll post that actually, come to think of it, in the description section of this video. But I'm going to share this video with this doctor, and we're going to go through it. It's increased in speed a little bit at 1.25x because I do want to get through it. It's not even 7 minutes long, so we should be able to hopefully keep this to under a 20-minute video. I'll try my best, but I do want to make sure that we are giving you the best possible reasoning why both you should coordinate with your doctor, even if you do order your own labs, and what gaps are missing here when you hear these kind of messages from a so-called expert. And I would say is an expert, but in the ways conveyed, this is very dangerous, and I would say exceedingly problematic enough for me to want to share with you and give details as to the problems within. Okay, so let's go ahead and start and listen to this doctor who says he doesn't go to the doctor and orders his own lab work, pays for them cash. Let's go.
Hi everyone, Dr. Suneel Dhand, internal medicine physician. Welcome to another video. Crucial blood tests to get. As I've said many times before, I have no interest whatsoever in regular healthcare interactions. I go outside of the system.
Okay, the system. Well, I couldn't be more sympathetic in the sense that if you know my training was in primary care internal medicine, I thought I would go into primary care internal medicine with the theme of being a lifestyle medicine first, preventive medicine doctor, and then use medications only where necessary to learn to give some credit to Dr. D's comment regarding the system, that there was no way I was going to be able to do what I needed to do and what I felt I was really destined to do in terms of guiding people and coaching them with lifestyle as medicine as the first drug. So I went right into intensive lifestyle intervention programming and learned about them in detail, had a great mentor in Dr. Michael Doyle. I then started to then build my own programs from scratch. I've done it actually now multiple times, including at Trinity Health, including at Henry Ford Health, where I was regional medical director and built an entire standardization program for all of their hospitals within the system. And in fact, this Flex 5 methodology that I designed, I developed, is licensed to and has been accepted by the Henry Ford Health System as the standard methodology to unify all metabolic health programs across the Henry Ford Health System. But I don't ever recommend that you go outside the system per se. When we were doing testing and we were helping patients, we always communicated with the primary care physician, empowering the primary care physician to help make patients more educated and able to manage in 5 to 10 minutes whatever questions they might have, which, by the way, is a bit of a myth. When you go in for an annual physical, you'll spend some good time with your doctor. I have a primary care doctor, and I hate to say this as we start to continue more, but A doctor who treats themselves as a fool for a patient is a well-known quote for a reason.
And get my own blood test done every 12 to 18 months or so. And that really says something because since I arrived in the United States, I have.
Now, he doesn't say it, but a couple $100 out of pocket. People don't have that, Dr. D. And even if they do, properly ordered, it would be covered by insurance. And then they would have the proper medical legal relationship with a physician to then discuss the lab results for which they may not know what to do or how to interpret, or may not know what to do with results, and then therefore see someone else that is not licensed or try to get outside the system medications online or otherwise to self-manage. That is a recipe for disaster, sir.
Excellent healthcare insurance, and the blood test would all be paid for. But what am I going to do? Get the blood test done and then sit down with a regular primary care doctor who barely.
Yes, you would. Now listen to what is about to be said here and how insulting it is. Who barely what?
Has any time with me and is going through a tick box of questions to ask. They won't get to know me. They will.
How do you know this, doctor? A tick box? Yes, there are requirements. I lament them. I understand what you're saying. The issue of throwing the baby out with the bathwater, though, is a bit egregious. They definitely can get to know you. I see hardworking primary care physicians, of which I know an extensive number. I have an extensive network of colleagues in primary care. I was trained in primary care, and I find it an insult that you would say sweepingly that they are not going to be able to do anything helpful for you or get to know you whatsoever. That is a terrible statement, only undermining a system that needs help and colleagues like you and I to help primary care physicians that are already downtrodden enough with numerous going over into concierge medicine, which is fine, by the way, which is something you could offer. If you're going to be spending hundreds of dollars, why not just go ahead and spend hundreds of dollars on getting a concierge primary care physician who would therefore then be able to have the time to spend with you as an individual, but in terms of population health, starts to take primary care numbers away, primary care physician numbers away, and therefore concentrate more patients for primary care, downtrodden primary care physicians that we need to help society help out by providing information and education that will make them more informed consumers to do better with the short amount of time they have, and not try to completely go out and try to blast the system, which could leave people with absolutely no care for issues that you might end up have recommended they find or end up having responsibility for, since you've recommended they have the result of which they won't have anything to do with. And I'll give you a number of examples in this rather ridiculous video that you have done.
Mindlessly go through their protocol as they have to do really within our current system, and then they will want to throw all of their recommendations at me, including injections. No thank you, I would rather think things through myself.
Including injections? Sounds like scaremongering to me. Are you talking about people's legitimate fear over what happened with COVID vaccinations? Fair enough. It's a nuanced discussion. Happy to have it with you. I regret the fact that I had 3 injections myself, but to then conflate this with mindless doctor giving bunch of recommendations that are robotic in nature and thoughtless, ridiculous, offensive. You should actually be reprimanded, sir.
And be my own doctor. But of course, I understand that everybody doesn't have this advantage.
Be my own doctor. A doctor who treats themselves, sir, has a fool for a patient.
I'm a physician myself, and I know what crucial blood tests to get every 12 to 18 months or so. And in
First of all, people with diabetes, which is running rampant in this country, require blood tests far more often than 12 to 18 months. Did you caveat that, sir? Did you think about how many people have prediabetes, for instance, and don't understand the lab ranges and are going to be detected, forgetting even about the 30 plus million that have type 2 diabetes that need lab testing more often than every 12 to 18 months, including someone with prediabetes who deserves to know that they should be rechecking their A1C in less than that? That's just one example of how ridiculous your blanket statements are. Is it offensive and arrogant manner in which you are spreading this so-called message of self-care, which is, if anything, horrible self-care? People need to know what they know and know what they don't know. And sir, I don't think you know how much damage you're doing by making these ridiculous, sweeping, and frankly selfish, for probably clicks, which I won't get nearly as many as you, so-called recommendations.
Countries like the United States and United Kingdom, it's very easy to order your own blood test. You don't need a doctor's order. And I've used various companies in the United States, including Quest, but there are many facilities in most areas. And I get blood tests done every 12 to 18 months or so.
Okay, he said this twice now. Yes, there are outfits like Quest and LabCorp in which you can order your own test, pay cash, a lot of money that you wouldn't otherwise need if a physician ordered the testing, or you could take those hundreds of dollars and consider investing again in a concierge primary care doctor that would definitely, by definition, have plenty of time to spend with you. Although I completely disagree that all primary care physicians are mindless people just clicking off check boxes and making mindless recommendations about injections. I mean, wow.
Of course, everybody is different, but here are the blood tests that...
Isn't that the point? Everybody is different. If everybody is different, Dr. D, then someone needs to be a differentiator that has the skills and knowledge to be able to do that differentiating.
I routinely get, and I wanted to share these with you in this video. Number one, the complete blood count, or CBC. I believe they still call it FBC in the...
Okay, CBC. He is going to say basically nothing about what to do with these results. He just says basics about what this and that means. It includes white blood cell count. By the way, that white blood cell count can be segmented into different types of white blood cells, such as basically neutrophils, which fight bacteria. I happen to have a neutropenia, a condition in which I certainly need to have specialists monitored. I've even gone to University of Michigan because, again, a doctor who treats himself as a fool for a patient, to lymphocytes, which are essentially cells that help with viruses, and not to overly simplify, but you can tell beyond white blood cells what type of white blood cells, and in that, no information given here about that breakdown whatsoever. I know what he's going to say next, so I'll say about hemoglobin. Well, what happens if that hemoglobin is low or high? You could have polycythemia. That polycythemia, high hemoglobin, would be one aspect of what you might see in polycythemia. That's when too many red blood cells are made. Could be secondary to lung disease, could be secondary to untreated severe obstructive sleep apnea, which most people are in denial about and don't want to do anything about. It could be because of polycythemia rubra vera, a genetic condition. I mean, there's nothing that's being discussed here. And in fact, when it comes to hemoglobin, he will simply make a minor reference to a low iron, and then discuss iron in a way I'll tell you is one of the weakest, probably the second, maybe arguably the weakest piece of guidance, if you will, a recommendation he makes in all these lab tests.
The United Kingdom. And this looks for crucial components in the blood, including hemoglobin. Are your red blood cells at an adequate level? White cell count, which is a marker of infection or inflammation, it goes up if you have either of those. And also platelets, which are a crucial component of the blood involved in clotting. Number two, a C.
Okay, did you hear any recommendations, much of any serious recommendations, what to do with the results? Nope, and you're not going to. Right test, it's a good test. It's one part of many. The comprehensive metabolic panel he's about to discuss here is also a good test, but I'll make some comments here as well.
MP, a complete metabolic panel. This is different from a BMP, which is more basic and will only tell you the kidney function and the electrolytes, including sodium and potassium.
Not correct. It also tells you glucose. Let's see if he mentions that, because that is a critical component of both a basic metabolic panel, BMP, and comprehensive metabolic panel, which isn't actually comprehensive. It's just more detail and does include a few extra lab tests like liver function tests, which he'll discuss here. And I know he mentions glucose as being part of comprehensive metabolic panel, but I don't think he mentions glucose as being part of basic metabolic panel. Let's see if I'm wrong.
But a complete metabolic panel also includes liver function tests. Very important to regularly get those checked. Also included in that are your
Why? Why are liver function tests, doctor, important to get? For what reason? Why? Maybe it could be the pandemic we have of fatty liver disease. Could that be a reason why? Would you like to tell people about alcohol too, and that there's generally a higher AST to ALT? These are the two liver tests he's talking about, by the way, AST and ALT. There's a higher AST to ALT ratio when it's alcohol fatty liver disease versus higher ALT to AST ratio when it's calorie-based or associated with insulin resistance and type 2 diabetes fatty liver disease. Oh, no comment whatsoever. How about when it is related to statin drug therapy and the levels at which we need to be concerned or not concerned based on statin drug therapy? Any comments at all regarding this, or just it's important? Important what? How? People get these tests. What are they supposed to do with these tests? Dr. D, very, very inappropriate.
protein levels and your calcium levels. Number 3, HbA.
Okay. Protein levels are actually far more in the sense that he's trying to convey them in terms of your protein status and whether you have adequate protein intake. It might be a risk for muscle loss over time related to the albumin. There's protein in the comprehensive metabolic panel. It includes antibodies and other proteins. And then there's albumin that's specific to a long-term test of dietary, if you will, protein intake. It's almost like a hemoglobin A1C of protein intake. There's a shorter term test that's called prealbumin that you could get, but it's not appropriate in this context and would be more even intimately related to shorter term protein intake. But the protein, dietary protein intake he's referring to, it seems like, because I can't tell, it's so ambiguous, it's almost worthless, is actually related to albumin, which is also on the comprehensive metabolic panel, but it's not something you should be trying to interpret yourself. There's also bilirubin he doesn't mention, which could be an indication of gallbladder disease and other metabolic disorders. I will just keep going here.
A1C or glycosylated hemoglobin. This is a test for insulin resistance, prediabetes, and diabetes.
No, it is not a test for insulin resistance, sir. Fortunately, you did mention later, checking a fasting insulin, which is a good idea. And I'm going to praise you on that one point, even though you didn't do adequate explaining of what the results mean, as I do in my free webinar, which I will post in the description section. A1C is simply a measure of your average blood sugar over the last 6 to 12 weeks. It's actually 80% the last 6 weeks, but you could make a case that it's really about 12 weeks worth of an estimation of your average non-fasting and fasting blood sugars, everything all in one, over the last 3 months, 12 weeks approximately. It does not detect insulin resistance, and he contradicts himself by mentioning that fasting insulin would be something better to check for early insulin resistance, as I explained in detail in the Flex 5 Masterclass, by the way. And as far as the first steps towards diabetes is first high insulin, normal blood sugar, then high blood sugar, which is typically high after eating 4 out of 5 times prior to the fasting glucose going up. And since A1C checks for both, it's a good test, but it's going to just still check the tip of the iceberg when one of the two, usually the after meal blood sugar, goes up. Then you finally have a blood sugar or A1C rise. It's insulin resistance. It does not detect. It is not a detector of insulin resistance. If it is, it's a very crude and late measure of insulin resistance, simply a measure of the late stages of insulin resistance after the insulin production of the pancreas has burnt out. And finally, then years later of many years of insulin resistance, then we end up getting a manifestation of elevated blood sugar.
And it gauges blood sugar levels over a 3-month period. Number 4,
again, 80% of A1C is in this last 6 weeks. So you could actually check it within 6 weeks and get a pretty good idea of directionality, but nevertheless.
fasting insulin level. Not many doctors will tell you this, but fasting insulin levels are just as, if not more important than glucose levels.
Okay, stop. First of all, he was going right, and then he went wrong. Fasting insulin is impossible to interpret without a fasting glucose level, and the homeostatic model assessment of insulin resistance, the HOMA-IR actually calculation that he's talking about in a moment, which isn't even really necessary. I'll make it very simple for you right now. As a matter of fact, you can't interpret a fasting insulin without a glucose. You need a fasting insulin check concomitantly in the same blood draw as a fasting glucose together to get a HOMA score or even to interpret it. And to be honest with you, if you're talking about someone that is not yet had years of type 2 diabetes, doesn't have insulin cell production burnout, or what we call beta cells, the cells in the pancreas that make insulin, a fasting insulin level of 5 or less associated with a fasting glucose of less than 100 in our units in the United States, which are in milligrams per deciliter. If you want to interpret less than 100 by European or international standards, you would divide by 18 because that's the molecular weight of glucose. So just divide, for instance, 100 by 18, and you get the threshold for a fasting glucose that would be considered pre-diabetes, 100 milligram per deciliter to 125 milligram per deciliter for pre-diabetes. Although I would say fasting glucose is pretty crude and not the best, but I'm going to give you the guidelines. And then 126 milligrams per deciliter or higher you have diabetes, if it confirmed on multiple occasions. And that would go with A1C as well, which you didn't even mention. The pre-diabetes range for A1C is 5.7 to 6.4. If you go with the American Diabetes Association, it is actually 5.5 to 6.4 if you go with the American Association of Clinical Endocrinologists, which I tend to be more in line with because I like to catch things early. And as crude as A1C is, I would rather be on the early side. But as Dr. D mentioned, fasting insulin is a better, even earlier, better detector, but cannot be interpreted without a fasting glucose. You have to have both together to get a insulin resistance score, but I'm going to keep it similar. You don't even need to do a HOMA. The ideal, and if you want to ask me what a way to personalize optimal weight is, because weight is really a reflection of concern of insulin resistance, unless you're talking about an orthopedic issue, and then it's a mechanical issue between you and your orthopedic physician, you still have to see a doctor, Dr. D. Is going to be whatever weight you are when a fasting insulin is at 5 or less with a fasting glucose of double digits, okay? Less than 100. Whew.
So a fasting glucose level will be on your CMP blood test. By the
Also on your BMP, again, as I mentioned earlier, another one of the major problems I have with this is the level of inadequate information. Basic metabolic panel is fine if you are well known to not have any liver issues. You don't always have to get a comprehensive metabolic panel. A basic metabolic panel for many people is fine. I'm not saying whether it is for you because you should talk to your licensed healthcare provider. But nevertheless, it does include a glucose. So I don't know why he's implying that a glucose is only part of a comprehensive metabolic panel and not a basic metabolic panel.
way, these blood tests should be done first thing in the morning. Fasting, hopefully you already know that.
Okay. Hopefully you already know that. Let me give you some added information. Ironically, for these fasting blood tests, you should remember that there's fasting for God and fasting for people who think they're God, and hydrate. We're not fasting for religious purposes, and therefore fasting without hydration, just calorie fasting is all that we need. In other words, 8 hours would be adequate, by the way. Don't need to even go 10 or 14 hours. If your blood sugar or insulin levels are high after 8 hours of not eating, we have an issue. That being said, I'm well hydrated for practical reasons. First, finding a vein easier when you're not dehydrated. I'm going to tell you how to detect whether you're not dehydrated or not, or well hydrated, if you will. Also, because your blood sugar can look higher than it really normally would be if you are not hydrated well, because blood sugar is measured in milligrams of glucose or sugar per deciliter of blood. It's a ratio. And that deciliter of blood, that denominator, is going to be lower if you're dehydrated. So it will make your blood sugar look higher than it really is because you're more like a raisin than a grape, if you will, when you go into the doctor's office. So you need to drink enough fluid, is my opinion, that by the time you get to the doctor's office, you want to pee for a second time. So you wake up, you have to pee, great. Drink water, drink water, drink water, and hopefully you'll want to pee. That way, you know, you're tanked up by the time you take your fasting blood work. Another issue is that he hasn't even mentioned in the comprehensive metabolic panel is a critical component of kidney function test. That's also part of the basic metabolic panel. And on the basic metabolic panel, the creatinine or comprehensive metabolic panel, the creatinine and the BUN or blood urea nitrogen combined with your age and gender will be used to calculate what's called a glomerular filtration rate. That is the rate in which your kidneys are filtering or cleaning, if you will, your blood. GFR stands for glomerular filtration rate, and it is expressed in milliliters per minute of blood. So how many milliliters per minute of blood your kidneys are cleaning or filtering, if you will, is what the GFR is. G just stands for glomeruli. Glomeruli are special little arrangements of blood vessels and tubules that concentrate and make and refine urine, of which there are a million glomeruli in each kidney when you are born. And then over time, they may decrease. As he's mentioned aging in a moment here, that's natural aging, not that's actually a different video. But the truth is, age-related loss in glomerular or kidney function is one thing. What's really killing glomerular function in the United States is diabetes and hypertension, the number 1 and 2 causes of renal disease and kidney failure. Let's move on.
And a fasting insulin level coupled with a fasting glucose level will enable the calculation of the HOMA-IR.
Oh, but earlier I thought you said that it's not important to do a glucose. Then you said it is important to do a glucose, and this kind of mixed messaging. Sometimes, doctor, slow down. Slow down. Okay, haste makes waste. When you give information that is partial like this, it's confusing and it leads people to ultimately nothing but you getting clicks. and having people who love to stay away from doctors because of fear for things that they might have too much fear of. That's true, but also things that they can then disregard, will miss, and can die from.
Which is a very important calculation for insulin resistance syndrome. We don't use it anywhere nearly enough, and I've made videos about this crucial blood test before. Number 5, a vitamin D.
I've just given you a simple, easy way to understand HOMA, if you will, insulin resistance. You don't even need to use the calculator. If you want to look one up, that's fine. But generally speaking, fasting insulin 5 or less with fasting glucose less than 100, and you've got yourself as good of an insulin sensitive status as you can detect with this test. Okay, you want to see something happen live? That's going to be very interesting. We'll continue to listen as I plug in for power. So let's go ahead and continue to listen, and I'll keep track while I plug in for power.
D level. Millions of people out there are walking around with suboptimal vitamin D levels. We all know that vitamin D is important for strong bones, but it is also extremely important for good metabolic and immune health. So a good idea to check a vitamin D, OHD level regularly, particularly if you live in the northern hemisphere. Number 6, an iron level. I'm a big fan of checking iron levels because many people out there, especially females, are iron deficient. They have iron deficiency anemia. Number 7, CRP levels.
Let us go back to, before we get to iron and then CRP, which is, I just realized another major gaffe from Dr. D here, is it's not OH or whatever he was saying. It's 25 hydroxy vitamin D. That is the blood test that he's talking about. There's a lot of controversy over this, and I generally agree with the Endocrine Society guidelines. You can look them up. In fact, let me make a note to include the vitamin D guidelines from the Endocrine Society in the description. Okay, and the blood test, though, is 25 hydroxy vitamin D. It is not just 25 or vitamin D OH or whatever he just mentioned. He's talking about 25 hydroxy vitamin D, but the actual test that you would ask for, you would order, or you should talk to your doctor about whether you need or not, because you may not. And there's a lot of over testing in vitamin D, and there's a lot of people who believe that super high levels, far more than evidence would suggest. And I used to be a vitamin D supplement evangelist. Don't make no mistake. I looked at the observational data where there's a lot of guilt by association, credit by association, reverse causation, confounding variables, and then finally saw massive randomized controlled trials clarify things, like the VITAL trial, tens of thousands of people randomized to placebo versus vitamin D. And we saw that when blood levels were over 30 and you give people a couple thousand extra units to get to that levels of 40 and higher, nothing happened. The vitamin D, 25 hydroxy vitamin D level of adequacy is almost assuredly 30 nanograms per milliliter. Maybe even arguably 20, but I'm okay with 30. Used to think it was 40 to 60. And the fact is, you gotta follow human randomized control trial data. And Dr. D, I think you're just coming off now as a guru and evangelist rather than someone that's an actual science-based clinician. Nevertheless, so there was, I think was iron not just discussed? Okay. I think he just briefly said iron level. This is a huge problem I have with this video, because first of all, there are people with insufficient and excess iron happening in the United States, sometimes in the same household, neither of which is good. The blood test, he mentioned iron is useless. You do not even ever order an iron by itself. You order what's called an iron saturation, which includes iron and transferrin, and you come up with a percentage. That iron saturation percentage is critical for people when you're looking for hemochromatosis, which is a deadly disease of iron overload based on genetic hyperabsorption of iron, and when found can be life-saving. And you get phlebotomy, and if you look it up yourself, you don't have a doctor in your corner, you don't know what you're doing with this test, and you are having a big problem, especially if it's in the upper end of normal. You're early on in the issue of hemochromatosis, let's say because you're a perimenopausal female and you've been saved from your hemochromatosis because you've had heavier periods and maybe even menorrhagia, so there's been no manifestation of this high iron. Now you're about to start losing your loss of iron every month, and then your iron saturation starts going up, but not yet abnormal, but you would have detected it with a ferritin, which he doesn't even mention is not only useful for the condition I'm talking about, early detection of hemochromatosis, but is the only iron test that is abnormal and the 10 times more common, so more risk for population. Even if individually less severe than hemochromatosis, iron overload condition called insulin resistance hepatic iron overload, in which you have high ferritin with normal iron saturation. Iron saturation is a specific test, by the way. He's just mentioned iron. Iron plus transferrin together make iron saturation. You don't even need to remember any of that. It's iron saturation. That can be normal, though, in the case of a iron overload condition that's not as severe as hemochromatosis, but is iron overload due to insulin resistance and hyperabsorption of iron due to insulin resistance, which then the iron makes insulin resistance worse, which makes the hyperabsorption of iron worse, kind of get into a vicious cycle, and can actually be improved also by not only resolving the insulin resistance and then avoiding excess iron intake, whether that was from red meat, whether it's from cooking in a cast iron skillet, whether it is from the high amounts of iron in refined grains, the so-called reduced iron, and that's reduced in terms of its oxidative state, not reduced in terms of its level. In fact, iron is supplemented or enriched in refined grains to a level that's even higher than natural whole grains, which also have factors in them that can bind iron and avoid overabsorption. So when you're having a refined wheat bun with high iron supplemented in it called enrichment, and then you have iron in the middle with red meat, let alone if you're cooking it on a cast iron skillet, which would be great if you have low iron to cook in a cast iron skillet, but not necessarily if you have high iron. And we've seen many cases where the wife and the children have low iron, the husband has high iron. The recommendations you're giving here, Dr. D, I am sorry, they are crap. They are totally irresponsible crap for helping anyone but yourself to get clicks. I'm embarrassed, frankly. I'm very, very embarrassed. Now we're going to go into this one, which is another mistake he's making on CRP, but let's make him make a statement first.
C-reactive protein. I've made videos about this before, but this is an excellent test. It's underutilized for detecting generalized inflammation within the body. There are specific forms of CRP, but a general C-reactive test is usually a good one to get.
A general C-reactive test is usually a good one to get. I am completely lost in the ambiguity of that bull capital S with a hit, Dr. D. Clarify what most people need in terms of the biggest risk that we have: cardiovascular disease, whether it's in terms of mortality, heart failure, heart attack, stroke, death from either, is a high sensitivity C-reactive protein, an HS-CRP, sometimes called a cardio-CRP. That is the test by which we have numbers that can be useful for a much larger majority of people, if useful at all, because it's so overly sensitive that it can detect inflammation irrelevant largely to health in terms of cardiovascular disease. It is a sensitive enough test that HSCRP, if less than 1, great. Because if you don't have an elevated HSCRP, you don't have much inflammation anywhere. It's so hypersensitive that if it's low, phenomenal, great. If it's elevated, we're not really sure. You have to go ahead and dig further. With who? Yourself, Dr. D? No, you have to go see a licensed healthcare provider, whether it's a primary care doctor or a rheumatologist that has expertise in the area of inflammation and detecting what the source is. You're being irresponsible by recommending a test that is largely worthless, a general CRP, which is not sensitive enough to detect even the concern that we have that's the biggest in the United States. And even then, an HSCRP, I hope in the videos that you have made, needs to be clarified as a very sensitive but non-specific test. We've even seen, for instance, the Bolivian Chimane. This is a tribe that still lives in the Amazon in Bolivia, semi-modern. They're not hunter-gatherers. They're more like semi-modern horticulturalists. Clearly, they gather a lot of vegetation, but they grow some of their own grain. They eat fish and they eat bushmeat. They're very active. 6 digits worth of 5 digits worth of steps per day easily, even on the lower end. And they have some of the lowest rates of heart disease ever seen on the face of the earth. But they have high HSCRP, Dr. D. Why is that? You know why? Probably not. Well, obviously, because their inflammation is due to insect bites and mild intestinal infections from drinking river water, et cetera, but has not anything to do with their cardiovascular system because of the population that they are. So you have to individualize the recommendations as a licensed healthcare professional with the person you are recommending tests on, the tests of which in this case, I don't know about your other CRP videos, isn't even very useful or accurate and actually misleading and could cause people to lose the opportunity to act on something earlier, potentially even a massive cardiovascular event than otherwise would be from watching this video.
To basically screen for underlying inflammation. People who have inflammatory disorders or an infection particularly will have elevated CRP. Number 8, a lipid panel.
Okay, so you have an infection. Then what are you supposed to do? Deal with it yourself? Could be, yeah. If it's a cold, so on, etc. If you have a major, particularly, let's say a walking pneumonia, you're just supposed to, oh, it's just an infection. My white blood cells will take care of it. What are they supposed to do with that? And the whole point about infection is that you can't interpret a high sensitivity C-reactive protein in the context of an infection. You wait till it resolves and everything is as calm as possible, if you will, inside the body, so that all you're detecting is that chronic cardiometabolic inflammation. Sorry, I have to fill in the gaps for you here, Doc, but sometimes haste makes waste. Don't make a video till you have some time to do it. Maybe you'll end up making less videos. You might have less followers. You might make less money on YouTube. I certainly don't make any, but it is what it is.
Also known as a cholesterol blood test. I put this way down the list because I'm not a huge believer in the lipid cholesterol hypothesis.
Which tells me that this guy is very underinformed. It is not a hypothesis, doctor. The contribution of atherogenic particles in cardiovascular disease is not in question. Of course, there are people with different susceptibilities, different arterial structures, different shear forces, different levels of blood pressure. But as a fact, we know that atherogenic particles, meaning apolipoprotein B, ironically, I would argue a test that's now very inexpensive and far more accurate than what you can get on a substantially more accurate than what you can get on a total lipid panel, I should say. But even then, in a lipid panel, you don't even mention the most accurate or the least inaccurate or the most highly correlated with apolipoprotein B. Everybody, by the way, you should have this test done for your own sake for detecting the most accurate contribution to cardiovascular disease from the lipid world is in non-HDL, a total cholesterol, let's say 140. You should be so lucky. That's about where my level is, 140, 150, not due to drugs, but based on lifestyle, less minus the HDL. So if let's say it's 150 for your cholesterol total and your non-HDL is 40, you have your HDL is 40, total cholesterol of 150, HDL of 40, so-called good cholesterol. It's really a particle that helps with reverse cholesterol transport and basically pulling cholesterol out of the blood vessels and then handing it off to LDL particles, which then go to the liver, and then the liver grabs it, takes it, and you poop it out. Hopefully, if your liver's good at clearing your blood of cholesterol, which it will be without such significant saturated fat intake, which inhibits the liver's ability to clear the blood of cholesterol. So non-HDL is National Lipid Association recognized, by the way, does not require fasting, but I would still have it done fasting for the fasting insulin. If you're not having a fasting insulin done, you could be just as well off with a non-fasting, arguably even better off as you're stress testing your triglyceride control with a non-fasting lipid panel. But that best number would be your non-HDL. Maybe some contribution from triglycerides, which I would say should be under 100. But if you're getting to a fasting insulin of 5 or less with a fasting glucose of 100 or less, or I should say less than 100, you are almost assuredly going to have excellent triglycerides. If you don't, you have a genetic issue for which you need to see a licensed healthcare provider. Oh my. So let's go on here. And I will have to mention another lipid test, but I want to give him a moment here before I discuss a critical test that we need to have done at least once in a lifetime that's not even mentioned here.
I believe we're way too aggressive at treating this, and we focus on band-aids and treating numbers rather than getting at the root cause of the problem.
Really? Is that what you do, Dr. D? I understand what you're saying. Too often a statin, preferably low dose, combined with ezetimibe, is thrown at people who have elevated numbers. But those drugs have been extremely helpful band-aids. It does not mean that we should not be recommending therapeutic lifestyle changes first. I am completely on board with that, although I don't know what you do to give a course or an option for people to actually learn about this if they wish, which you can if you want. It'll be in the description notes. We will make sure that you have access to myflex5.com, MYFLEX, then the number 5. So mymyflex5.com, and you can click on the sandwich in the upper right and look up Masterclass. That's where you really get a 14-hour comprehensive integrated review of what medications mean, what labs mean, to work with your primary care doctor as a more informed and empowered patient, and then learn about all 5 of the domains of skills and knowledge that are necessary to achieve and maintain healthy longevity. Psychology, nutrition, ethnic agnostic, by the way, physical activity, not just about exercise. In fact, have we gone on for about 20 minutes? I'm going to do some squats here. Environments, your food environment, your social environment, skills in physical environment, as well as fifthly, accountability. Wow. Never have I seen my colleagues thrown under the bus so badly by someone else that is supposedly a board certified internal medicine and lifestyle medicine specialist. Atrocious, sir. If you show up in October at the American College of Lifestyle Medicine, be ready to be held accountable.
But nevertheless, it's still a good test to get. It should be fasting ideally, and the blood test will enable us to see what the total cholesterol is.
No, sir, it should not be fasting ideally, unless it's because of the fasting insulin, which has nothing to do with anything but practicality, not to optimize the lipid test. You are extremely behind the times when it comes to lipids. You're not only extremely behind the times in terms of lipids, not even mentioning non-HDL cholesterol, claiming that a lipid panel has to be fasting. It does not. You haven't even mentioned lipoprotein little a. Lipoprotein little a, now is a good time to mention, is the most common genetic disorder for lipids. I have a very high level in the world. 1 in 5 people have it in the United States. Less than 1% have even been checked. People deserve at least once in a lifetime check of this lipid level. Lipoprotein little a, L-I-P-O, then protein, all in one word. Lipoprotein little a means at the end of lipoprotein, the word, there is parentheses and a little a in the middle. So lipoprotein, parentheses, little a, close parentheses, short LP little a. Some people even just call it LPA. There's 3 different variations, whatever way you want to call it. Talk to your doctor. Talk to your doctor. If you want to get this on your own, that's fine. But still, the reason you need to talk to your doctor, because if it's elevated, we have to be very intensive about controlling everything we can. Blood pressure, insulin sensitivity, apolipoprotein B or non-HDL, does neither of which requires fasting. Dr. D, get with the program. Don't be so overconfident in your skills. It's a bit arrogant. That being said, I hope that people will get this blood test checked. It may be worth checking it twice in a lifetime. And I would hope that you're able to get your children checked if you're at high level, your brothers, sisters, all first degree family members for sure, probably even wider, because it's so common in 1 in 5 people and maybe up to 1 in 3 African Americans that really everyone should be checked anyway once in a lifetime. After menopause, the level can go up due to estrogen's influence on keeping lipoprotein little a production in the liver lower. Lipoprotein little a essentially, by the way, is an LDL molecule or particle that has an extra tail protein that causes it to be more toxic, more able to penetrate the arterial wall, as well as the aortic valve. It's associated with increased risk of aortic valve stenosis, as well as reducing the body's ability to break up blood clots. It acts as a enzyme inhibitor of an enzyme that breaks down blood clots, essentially acting like a decoy as a blood clot, saying, hey, blood clot breakdown enzymes, come over here. Ha, 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 just kidding. There's a blood clot over there you're missing, causing a heart attack. Not good. But what's good to know is that if you have an elevated lipoprotein little a, which we considered above 30 milligrams per deciliter if you're using the old type of testing, or for very high, 50 milligram per deciliter. Better yet is to get it checked in nanomoles per liter. Labs are getting better about this more accurate way of measuring it. Nanomoles per liter, the thresholds would be high, 75, very high, over 125. Mine is about 127, for instance. And I have had a 0 coronary calcium score, meaning no calcium in the arteries, completely clean. In fact, if anything, estimated to be double-digit younger than my chronological years in my neck. And I've just recently had a peripheral arterial Doppler ultrasound showing completely widely patent lower extremity arteries as well, because I've had a lifestyle-driven low apolipoprotein B and blood pressure and excellent insulin sensitivity. Sorry, but you actually have to take time, Dr. D. Sorry to have to explain this to everybody else and yourself.
The triglycerides, the LDL, low density, quote unquote, bad cholesterol, and HDL, the high density, good cholesterol. All of those will show up.
He forgot the word lipoprotein. So low density lipoprotein, high density lipoprotein, HDL and LDL. These are spherical molecules, spherules, circles. Let's say it looks like kind of like a golf ball of protein with a complex outer layer that includes protein, and the inside contains cholesterol and triglycerides. The ratio of cholesterol to triglycerides per particle depends on obviously your insulin sensitivity status, most typically, and your triglyceride level, but it is low density lipoprotein, or HDL, high density lipoprotein. These are cholesterol and triglyceride carriers. They are particles that carry. They are not different forms of cholesterol. Cholesterol is cholesterol. It is no different whether it's carried in an HDL, a high-density lipoprotein molecule, or a low-density lipoprotein molecule, or very low-density VLDL lipoprotein molecule, or even the occasionally elevated, rarely intermediate density IDL lipoprotein particle. But to not use the word lipoprotein means you don't understand lipidology, sir. Take a course. Maybe take the Cardiometabolic Health certification course. I would highly recommend it.
On this blood test. Number 9, thyroid function. Your thyroid gland is involved in a multitude of different bodily processes. And if your thyroid isn't working properly, that can manifest in a number of different ways. Starting off typically with a TSH blood test. That's
Okay, when he said manifesting a number of different ways, I thought he was going to talk about symptomatology. Well, actually, that's not true. Often, thyroid is not symptomatic, low or high. Often it is if it's high, anxiety, heart arrhythmias, hyperthyroidism, in which TSH, thyroid stimulating hormone, which is the hormone from the pituitary gland, the pea-sized gland, it's just behind your cranium here, is the master gland that controls other hormone tissues in the body, releasing, in this case, thyroid stimulating hormone to tell your thyroid in your neck how much to make. There's other hormones like sex hormones, LSH and FSH, that tell the gonads how much sex hormones to make. There's also ACTH, which tells your adrenal glands how much adrenal hormone to make, etc. Corticosteroids, etc. In this case, though, know that there's an inverse relationship between TSH and thyroid hormone levels. When TSH is high, it means your thyroid is failing and you have low thyroid levels. Why would you check it instead of just directly checking thyroid levels? Because thyroid levels don't go actually absolute level low for a while. You can kind of whip that dead horse with your pituitary gland pushing thyroid stimulating hormone for your thyroid to make more thyroid. Even though it's getting tired, there's a phase of years in which it can still at least keep up normal levels at a really hard pace. And so if you just check thyroid hormone levels like a free T4 or T3, they'll be normal for a while, while TSH, a earlier and better indicator, is high. Same with high thyroid. If you're high, if you have an active nodule or an overactive thyroid in general, say you have Graves' disease, whatever the case may be, you can have then low thyroid stimulating hormone, low TSH. So just remember, TSH is inversely related to thyroid hormone as an early detector of either low or high levels. And you can get fatigue, of course. You can get skin issues and edema from low thyroid as well. And you're slow, you can have slower heart rate, fatigue, et cetera, but not necessarily always. You have to detect this earlier. And to be honest with you, if you have high risk, let's say you're an older female or there's a family history of autoimmune disease, you might actually ask your doctor to add a anti-TPO or anti-thyroperoxidase. But anti-TPO, Tom, Paul, Oscar blood test for the antibodies that are even earlier detection marker for eventually developing hypothyroidism. But if you do have low thyroid, that one of the issues is that it can cause your cholesterol to go up. So you wouldn't want to start someone on cholesterol medication unless you make sure that they have normal thyroid first. And it can increase the side effect risk, the muscle pain and muscle damage side effect risk of statins when you have a hypothyroid, even mildly hypothyroid condition. The good news is I will give you some tips here regarding statin therapy. The best way to use it is as an adjunct to lifestyle, not as a replacement for it. On that, Dr. D and I certainly do agree. And you would want to make sure that you use the lowest dose, lower end doses of more potent statins. You want more potent statins because they're not potent for side effects. They're potent in terms of their ability to lower the liver's ability to make cholesterol, which then causes the liver to grab cholesterol from the bloodstream to make bile, and which we then use for digestive juice and then poop out cholesterol. Because I knew in this video, you're absolutely sure that Dr. Tom's going to tell us how do we get rid of cholesterol. Do we pee it out? Do we sweat it out? Do we breathe it out? No, you poop it out. And if you want to get rid of it even better, by the way, keep saturated fat low, because saturated fat does the opposite of what statin drugs do. Saturated fat inhibits the liver's ability to express these receptors for LDL particles, to grab them, take them, and poop them out in the form of bile, but nevertheless, you poop out your cholesterol. And the best way to keep the risk low for statin drugs is to use a low dose of a potent statin, like a atorvastatin, pediatric dose 10 milligrams, or even 5 milligrams of rosuvastatin, combined with a cholesterol absorption inhibitor that's very benign relatively. Of course, discuss all of this with your licensed healthcare provider, called ezetimibe, which is the generic term for Zetia. Now, Zetia is generic. These are two very inexpensive medications now in combination. You can even, there are even generics of a low dose of atorvastatin with ezetimibe combined, or low dose rosuvastatin with ezetimibe combined, but they might be a little more expensive than just getting both of those generic. So you could ask for them to be separate as well. Now, that's deeper than I wanted to get as far as this, but I hope that's at least helpful in showing you how you have to fill in the gaps and how, sorry, Dr. T, actually a licensed healthcare provider can be helpful in a relationship that includes lab tests for which you have given squat worth of information what to do with, despite this is what you do for yourself. And I certainly hope, and I bet you have, I'd like to think, have had your lipoprotein little A checked.
The initial test for thyroid function, thyroid stimulating hormone. And if that is abnormal, then we do more tests, including T3 and T4 levels.
We do more tests? Who's we? You mean we, just the person ordering these tests expensively online for hundreds of dollars that you have that they may not? Who is we, Dr. D? Who is we? Do you mean a licensed healthcare provider? I don't know. Let's see.
Number 10, two other very important electrolytes to get are magnesium and phosphorus. A lot of people out there are walking around with low magnesium and low phosphorus levels. And in my opinion, it's a very good idea to get a baseline measurement to.
Okay. Low phosphorus is extremely rare. And what to do with blood tests, including magnesium, which arguably might be better tested in cellular form, like RBC magnesium is not as well correlated with magnesium status unless it's really low. But I'm okay with checking magnesium. I mean, but I don't know that I'd put it as a priority. I would still put someone that has blood pressure, for instance, and a magnesium level totally normal at 2. And still, I would suggest one of the supplements I take, frankly, and I'm not saying you take it, is magnesium citrate. I think that's one of the more challenging minerals to get to adequate level, even with a healthy eating pattern. But I wouldn't base it on a blood test as much as other metabolic health issues, bone health, but blood pressure in particular. So yes, would I put someone who has a low magnesium on a magnesium citrate? By the way, I wouldn't use oxide because magnesium oxide is cheaper but very poorly absorbed, probably 1/10 as well absorbed as magnesium citrate or magnesium malleate. Yeah. All right. Anyway.
To see what the numbers are and whether any supplementation is required. Number 11, testosterone levels. This is an important blood test for men of all ages to check because for a number of reasons, testosterone levels are decreasing across the board, primarily due to the environment.
Okay. Excuse me. Men of all ages. Why? So we can start putting young men on testosterone therapy? What's the end game here, sir? They're low level because of toxic environment, scaremongering. What is it you're saying here? Yes, there is very reasonable discussion around lower than normal testosterone, or maybe even suboptimal, that could be improved with therapeutic lifestyle changes and getting leaner, which would therefore then decrease the amount of adipose or body fat tissue. Body fat tissue contains an enzyme called aromatase that converts testosterone to estrogen. Actually, also in women would go the opposite direction and convert estrogen to testosterone, tending to equalize these hormones, which isn't necessarily a good thing when you have high body fat. And therefore, getting leaner, you can have the testosterone your body is producing stay testosterone and rise. Not necessarily during weight loss, but certainly after weight loss, and particularly if you add resistance training, which has been associated with improving testosterone levels. But what will happen, sir, with your recommendation, as far as I see it, and we only have a few seconds left on your video, is people are going to start reaching for TRT or testosterone replacement therapy, and then having suggestions to do so to their, well, maybe not even their doctor. They might just go online and get some testosterone replacement therapy, therefore reducing their own endogenous natural testosterone production and with it, their sperm count and their ability to have children in the future. Can you not see, sir, the ridiculosity of what you are doing here? It's unbelievable.
Environment, a toxic food environment, and also other environmental factors are leading to testosterone levels decreasing, and particularly.
Partial truths do not absolve you, sir. Yes, we do live in a toxic food environment. I lament that along with you, but the method in which you're dealing with it here, it's egregious, egregious.
If any man out there is having symptoms including lethargy, then testosterone is a good idea to check. So those.
Lethargy? Wow. There's many ways to go with lethargy, sir, including occult or maybe not so longer occult cancer. Oh, have you decided to even discuss GFR? As this could be, for all you know, multiple myeloma. It could kill a man within a year or two. Oh, we're just going to say lethargy, check a testosterone level on your own. People are clueless as to what to do with this generalized term that is associated with a bazillion things. And you now led people to think that testosterone is a good thing. In fact, could have guilt by association because they may have low testosterone since it's so common, but also a deadly disease explaining their lethargy. Could be pancreatic cancer, which if we don't catch it early, could be deadly. This is one of the most sad moments I have ever seen. I cannot even believe because this isn't just any healthcare practitioner, with all due respect to others. Uh, this is a apparently board certified internal medicine, board certified lifestyle medicine specialist putting out completely irresponsible bunk out on YouTube with 500,000 subscribers. And I think at the point this was, tens of thousands of views of this video. Unbelievable.
Those are some blood tests that I consider very important to check. And of course, everybody is different. Some people may need other blood tests. Some people may need blood tests less frequently. Some people may need blood tests more frequently.
And who's going to determine that, Dr. D? You've said that they should go outside the system. Are you going to jump on YouTube and try to individualize care for 500,000 people? Or might you want to empower your primary care colleagues by saying, go work with your primary care physician if you choose to go this route and find any abnormalities? And in fact, you should anyway, because there are things I have completely left out here, which could leave you at risk for early death. That does not mean you don't have the right and frankly the responsibility of agency in your own care. You are the pilot in your relationship with your primary care physician. They are just a navigator. That does not mean that they are not excellent navigators. You can put your foot down as to what your risk tolerances are and not. That's the issue I see here, is that this person who seems to be acting like they are a god does not understand that you can help drive a conversation with primary care or other licensed healthcare physicians in which you are the person in the driver's seat, but not completely ignoring flying without a navigator.
But because so many people have asked me, when you go outside the system, what blood tests do you consider important? I wanted to share that video with you.
Oh, that's why you did this video, sir? Because everybody asked what you do, and therefore you assumed and have basically made it pretty clear this is what they should do? Is this your way of individualizing care better because of a broken healthcare system? You think what you're offering is better? I would say it's an egregious, sad example of making something worse in the most selfish way I have seen ever from a board certified internal medicine and lifestyle medicine combined physician. I'm embarrassed. I'm embarrassed by your advocating this video as being a good thing for people to watch and then not assuming what's going to happen, which is a lot of miscare, a lot of lost opportunities, potential death, potentially even yourself being at the center of a lawsuit. I hope not. I really hope not. I pray not. And I hope this video helps people understand why you should not follow Dr. D's recommendation to get your own labs and then whatever else it is he's recommending do afterwards. Go online to find a drug, do some willy-nilly, who knows what he's recommending for follow-up tests if something is abnormal, not even anything. And we're only what? We're only 14, what's this going to be? 24 seconds away from the end. I have a feeling he's not going to recommend to work with your primary care doctor. Something tells me he's just going to recommend some other video of his own. Let's see.
Thanks everyone for watching. Feel free to comment down below. Check out my free guide, 10 ways to stay away from doctors with a...
Sorry. My free guide. Believe me, it's not free, people. He's getting paid. And that's okay. He's getting paid by YouTube. I am sure of that. With clickbait like this, 10 ways to stay away from doctors. And my apologies for doctors that may have done wrong, bad bedside manner, stressed, having gone through the pandemic. Some of them died. In fact, I just spoke to someone I met who's a mother of a child who shares the same school as I, and learned that her husband, surgeon, actually it was NFL flag football, excuse me, at the school that my children happen to go to. But anyway, whose husband died as a surgeon through the pandemic. I'm embarrassed, sir. I'm embarrassed by your crass and selfish lack of self-awareness. My free guide, 10 ways to stay away from doctors. I hope at least an apple a day keeps the doctor away is somewhere in there. But this whole message is causing people to throw the baby out with the bathwater, sir. And in that bathwater, some of them are going to throw themselves in with it and drown. This is an embarrassment.
The focus on metabolic health. That link is down below. Also check out my website and my newsletter. All the links are down below in the description. Hit the like button if you like this video and the bell button for more similar videos in the future. Stay strong, everyone, and we will speak again in the next video.
Okay, stay strong in the future. Well, I'm not so sure. Everyone that's hearing this message, Dr. D, is going to be able to stay strong. I hope they're even going to be able to stay alive, because that was crap. That was total crap. That was a joke and a sad one. I'm so sorry to have to be this emphatic about it. But if not, I will not be able to sleep at night, and I do not think that I will be able to really function with integrity. I do calling out colleagues when I have to, because sadly there are so many that have taken on a self-appointed guru approach that I hope I never do. And if I have ever said anything without caveating it, which I try my best to always do, that you must work with your licensed healthcare provider, that we're trying to empower you and your relationship with your primary care provider, and not kick them when they're down, if you will. And I have an excellent, by the way, my primary care provider is amazing, Dr. Steve Calabat. Maybe he's an exception. You say, oh, Dr. Rufai, you know how to make connections, this, that, and the other thing. Okay, fair enough. But I still don't go around the system. I'm still not going to violate the concept that a doctor who treats himself as a fool for a patient. And I've even suggested, if you're going to pay hundreds of dollars anyway, get concierge care. I think that's going to be harder for America, but maybe better for you, as people go out of primary care doctors who are rightfully trying to save themselves from the stress of the system, leave, and therefore take on much fewer patients. Good for the patients, but not so good for the population. I agree. We need to get to a system that is much more trained in lifestyle interventions, behavior modification, lifestyle as medicine first, with drugs, pills, procedures, injections secondary and only where necessary. I agree. That does not mean the approach that Dr. D is recommending is smart at all. It is completely and unwise, if not frankly idiotic. That being said, we also need to deal with legislation and how we go about producing food in this country. We have 200 plus million acres dedicated to commodity crops alone. One of them, corn by itself, 30% of our arable land. Going for what? Corn on the cob? No. It's going to confined animal feeding, horrendous CAFO scenarios in which animals are fattened up and marbled up with insulin resistance. So when you look at that fatty steak, you want to talk about insulin resistance and diabetes. There you go, right there. Last thing that you want your body is to have fat marbled in your muscle, or to high fructose corn syrup, or to ethanol and some tiny amounts for corn on the cob, and maybe other foods that might be like corn chips, corn flakes, etc. And we have 4 million acres dedicated to fruits and vegetables with almost no subsidies, when to calculate even the minimum amount of 2.5 cups of fruits and vegetables a day for every American would require 12 million acres. We have major problems. That's true. But to completely, entirely blow off licensed healthcare providers, that is a very selfish exploitation of the situation, Dr. D, and I'm embarrassed. But I will add, if you like this, by all means, click like. If you're seeing it on a different platform, Facebook, otherwise, click love, click hate, click whatever you like. Make a comment, share, subscribe if you feel appropriate, and I will put those links to the vitamin D recommendations of the Endocrine Society. If you're interested in learning about and mastering the mixed martial artistry of healthy longevity with the Flex 5 lifestyle, I'll put that in there as well. And I think there was some other pieces that I will add as well in terms of I will put a piece in about insulin resistance, hepatic iron overload. I think that that's worthwhile since I mentioned it. And make it a great day, right? Or not. It's up to you. Take care. Bye-bye.